Hello, friends, and welcome to episode 1192 of the Juicebox Podcast. Today, Dr. Marwa joins the Grand Round series. He's a pediatric endocrinologist who also teaches medical students from both Johns Hopkins and Washington University School of Medicine. Please don't forget that nothing you hear on the Juicebox Podcast should be considered advice, medical or otherwise. Always consult a physician before making any changes to your healthcare plan or becoming bold with insulin. The Diabetes Variables series from the Juicebox Podcast goes over all the little things that affect your diabetes that you might not think about. From travel and exercise to hydration and even trampolines. Juiceboxpodcast.com. Go up in the menu and click on Diabetes Variables. Are you a U.S. resident who has type 1 diabetes or is the caregiver of someone with type 1 and you'd like to help? You can do a lot right from your sofa with your phone in your hand. Go to t1dexchange.org/juicebox and complete their survey. When you do that, your answers to simple questions will help to move type 1 diabetes research forward. t1dexchange.org/juicebox. This episode of the Juicebox Podcast is sponsored by the only implantable sensor rated for long-term wear, up to 6 months, the Eversense CGM. EversenseCGM.com/juicebox. Today's episode of the Juicebox Podcast is sponsored by the Contour NextGen blood glucose meter. This is the meter that my daughter has on her person right now. It is incredibly accurate and waiting for you at contournext.com/juicebox. This show is sponsored today by the glucagon that my daughter carries, Gvoke HypoPen. Find out more at gvokeglucagon.com/juicebox.
Hey, thanks for having me. I'm Dr. Alvaro Marwa. I'm a pediatric endocrinologist at Sinai Hospital of Baltimore. I also teach medical students from Johns Hopkins University and George Washington University School of Medicine.
Wow. How did we get in contact?
Okay, so it's through a patient of mine who actually follows your podcast.
Mm-hmm.
She said, Dr. Marwa, you need to meet Scott. You need to be in that podcast. So I thank them for that introduction.
Oh, that's nice. Okay, so let's go over a couple things about you. How long have you been a pediatric endo?
All right, so I started fellowship back in 2018 in July. And so being in the field for now almost 6 years, been in quote unquote gainful employment since July 2021. So almost 3 years as an independent practitioner, but 6 years almost in total taking care of kids with diabetes. I'd like to start that my initial training experience was in Camp Sweeney. They threw us for a few weeks at camp with the campers. Suddenly the camp doctor that I have to prescribe and adjust insulin doses. And I was like, oh my gosh, that's so complicated. How can I even do something like this? So that really was a very good eye-opener for me to not just look at it from a medical standpoint, because as a pediatric resident, my exposure to diabetes was mostly through sick kids in the hospital or just a few brief clinic appointments. But that one-on-one contact in the camp just helped me really realize what kids with diabetes have to go through every single day. So kind of was a real eye-opener when I started fellowship 6 years ago.
Is that something they do with everyone, or were you just lucky to have that opportunity?
I think it's common practice for programs to send their fellows. At least in my program in UT Southwestern, this is considered work. So we actually do work hours at camp, but I'm not sure how other programs have it. But it's typically an opportunity that a lot of fellows like to kind of get themselves into.
You know, it's interesting. You think about it. The people who you were helping were probably thinking, oh, this guy, he knows what he's doing. And you were thinking, oh, how do I do this?
Right. And I was like, oh my gosh, it's so I don't know those devices. Can you please teach me what this guy does, what this button does? I understand basics of what, they all need insulin, but just how how we're operating it. It was so many new devices, so many new tools. That was the first time I actually got introduced to like a continuous glucose monitor, for example.
Mm-hmm.
So at that point, it still required a lot of calibration and a lot of work, but it was still a very, very fruitful experience, I would say.
When you start off, so let's kind of step through this. You leave high school, you go to college. When you're an undergrad, do you know you want to be a doctor?
Right. I'm an international medical graduate. So the way we do it in Saudi, where I went to medical school, is we do a high school and then directly into medical school. And that's called a Bachelor's of Medicine. It is equivalent to an MD. It's a longer program. So it's 6 years of medical school and a year of internship. Mm-hmm. So it's different from the way it's done typically in the United States and Canada, where typically you do undergrad and then you do the MCAT and then you decide to become a doctor and to become an MD. And that's like a postgraduate, not just straight from high school.
Yeah. So when you pick endocrinology, is there a reason that you chose endocrinology? Is it something that interested you about it, something you were good at or had a personal connection to? If you take insulin or sulfonylureas, you are at risk for your blood sugar going too low. You need a safety net when it matters most. Be ready with Gvoke HypoPen. My daughter carries Gvoke HypoPen everywhere she goes because it's a ready-to-use rescue pen for treating very low blood sugar in people with diabetes ages 2 and above that I trust. Low blood sugar emergencies can happen unexpectedly, and they demand quick action. Luckily, Gvoke HypoPen can be administered in 2 simple steps, even by yourself in certain situations. Show those around you where you store Gvoke HypoPen and how to use it. They need to know how to use Gvoke HypoPen before an emergency situation happens. Learn more about why Gvoke HypoPen is in Arden's Diabetes Toolkit at gvokeglucagon.com/juicebox. Gvoke shouldn't be used if you have a tumor in the gland on the top of your kidneys called a pheochromocytoma, or if you have a tumor in your pancreas called an insulinoma. Visit gvokeglucagon.com/risk for safety information.
Good question. So 0 personal connections at that point. So I was in the middle of pediatric residency. So basically graduated medical school, applied for residency, and matched to a US hospital in New York where I was doing pediatrics. But throughout those 3 years of training, it prepares me to become a general pediatrician. And then I have the opportunity to do 3 additional years of training in whatever field that I'm interested in. Mm-hmm. So whether it's being like a heart doctor, a cardiologist, or an endocrinologist, that comes in after we do those 3 years of general, whether it's internal medicine, if you want to be an adult endocrinologist, or a pediatrics, if you want to do a pediatric endocrinologist.
Okay.
So my first year as a pediatric resident, I was like, I know that I don't want to do general pediatrics. I think, yes, I love taking care of patients in a well child setting, but I do like to take care of kids who have chronic diseases. And so whether it being an asthma doctor or like a rheumatoid doctor or a heart doctor, I wanted to take it a step further. Mm. And so at that time, I was also doing my master's in public health. And I had, at that point, wanted to be involved in some kind of research. And during that time, the fellows who were in my program wanted a statistician to help them run those numbers and analysis. So I kind of find myself really with the group of endocrine fellows and the endocrine attendings who were amazing. And they got me involved into the diabetes research. And I was like, you know what? I actually like that, but I did not know how much I would love it. Mm-hmm. I was like, okay, I don't mind being an endo or an asthma doctor. But now it's like, looking back, I don't want to do anything but diabetes and endocrinology. So I'm glad that it's kind of the stars aligned this way for me.
Yeah. What about it captured your imagination?
I knew I love working with numbers and I'm a caring person. So I think I found that kind of right mix within pediatric endocrinology. But at that point, I was like, okay, I like to get results right away. So I was thinking maybe I can do a hospitalist job where I can just take care of very sick kids in the hospital or the ICU or neonatology. But then, like, I love to also have a work-life balance and spend the nights really at home with my family and not really have to spend so many nights of my adult career in the hospital. So that's where a subspecialty like endocrinology came in as a natural fit.
It's interesting how many little variables go into your course.
Right.
Yeah, really. It is really something. So once you decide that you're going to help kids, in a clinical setting, what do you know about diabetes, I guess, in the beginning? And how do you learn what you know now? Because it's not from medical, because people would be keen to believe like, oh, you go to medical school, so now you understand diabetes. That's not really how it works. So what's the pathway to really becoming proficient?
Right. So honestly, if without having a one-on-one diabetes training, I don't know how I would have been one, because yes, we do study how insulin works. That's something that they teach us in medical school. We study the different kinds of insulin. We study there is a pump. We study about DKA. They teach us in the hospital, of course, in the emergency room, how to take care of a sick child, but they don't really teach us what goes into the day-to-day management of diabetes. This is not a common thing that a general doctor, yes, they know that the kid needs insulin, but that's pretty much where it ends. In terms of what they teach us in pediatric training, not every pediatrician does endocrinology. So yes, a lot of my trainees currently in the hospital where I'm at, they just see kids with diabetes in the hospital. They never really have that connection with kids who never landed the hospital to begin with. So I think, again, if somebody wants to really get into diabetes, they need to actually experience and just deal with people who live with it.
Okay. Yeah. So it's just the experience, just having conversations, watching people struggle or succeed and taking information from that and building on top of it.
Absolutely. Yes. Yeah. And again, I was very, very lucky to have very good mentors in Dallas, where I did my fellowship. It was excellent, 16 endocrinologists, and I was their only fellow that year. So again, I felt that there's a lot of responsibility, but at the same time, it's that joy of learning something new and really being able to slowly understand how those doctors think about going about medically making the right decisions. But then after that, I realized there's very limited that doctors do in clinic appointments. And and this is always a question that I ask myself. It's like, what's my job as a diabetes doctor? Mm-hmm. What's my role? At this point, at least when I was in Dallas, the nurses would prepare all the prescriptions for diabetes. There is a protocol for when to do the labs and when to do the blood sugar checks. So, and even in terms of trend management, giving more or less carb ratios or long acting or just making a pump change, again, that's also mostly handled by our nursing and diabetes educator team. So it's kind of like that struggle. It's like diabetes is like no other disease. It's not just that you need the medicine. Pretty much everyone universally knows you need insulin for type 1 diabetes, but it's more of how can you tailor that treatment to that individual in front of you.
What did you decide that your job was?
At that point in Dallas, it was a much more structured way where we had diabetes educators routinely go in with the doctors for a visit. That all changed when I actually started here working at Sinai. It was COVID. Most people were remote. And we were just starting to get people back to the office. And I found myself basically doing it alone. It's like an all-man, it's a one-man show for the most part for the diabetes care and follow-up, when I had maybe 3 or 4 people help me in my visit. I kind of took a different approach to what other doctors might do. It was more of a concierge, so to speak, kind of practice in a community hospital, where I personally, again, was like, okay, somebody needs to provide that education. If I don't have the nursing task force, I don't have that skeleton. Hey, I still want my kids to get the best care possible. Yeah. And I'll just go ahead and do my own education. So I was very, very fortunate to have that capacity. It's like, yes, we are a smaller hospital and we have lots of hospitals in the area in Baltimore. It's not a big patient load. We get around maybe one new diabetic every single week. That's different from Dallas, for example, when I used to get a diabetic every single day. The load there was much bigger. So with having a diabetic every week, it was more of a process of how can I make sure that my patients are up to speed with that education process. So for me, my goal was mostly an educator, and I'm like a teacher and basically having a little curriculum in my mind, even though it's an unwritten curriculum about, okay, this is what you need to learn when you first leave the hospital. This is what you need to learn like around a month or two down the line. Of course, we all are different in how fast we learn, but at least understanding the basics, the concepts. I would like all my patients to learn how to do trend management. Of course, not everybody is able to do so, but it's mostly structuring the education. So I think founding my role as a physician educator was very, very fulfilling. I then decided, okay, you know what? I put in all those hours. I was able to put in my diabetes educator exam. I'm now one of the very few doctors who are certified diabetes educators and also board certified in advanced diabetes management. So basically, it's just from an A to Z kind of standpoint where I could just cover not just the doctor. Yes, I know how to look at prescriptions and look at trends and make dosing adjustments, but also educate and empower my patients to be able to really achieve what they need by the time I see them the next time. Of course, what do I use to measure? What's the variable that I'm tracking? It's like, of course, I track their time in range and their A1C. That everybody does. But of course, it's not just the A1C that happens in 3 months. I always ask myself, there's a lot of room, lots of window for opportunity between those visits that we could probably work on.
What do you feel like a newly diagnosed person needs to understand first? Like, it feels like you have it broken into steps.
Right.
What are the steps?
Diabetes is a life-changing diagnosis. There's a lot of stress, but then at that point, families are very eager to learn. And I found it that really what we teach in that first week or that first few weeks really stick with them for a very long period of time. And it's kind of like, this is the unshakable truth. So I think the most important things I teach or focus on, I think everyone can learn eventually how to check a sugar level or how to give insulin injection. This is not my point of focus. Our nurses in the hospital can, even they're not diabetes educators, they can also teach those basic mechanical skills. What I focus on is the understanding of diabetes targets. It's like, okay, this is a prediction game. Even if you're off by a point, upper or lower, you have the numbers to track. And to kind of teach a good target, I always say, I want to make diabetes a visible disease. And so I give Dexcoms during that first admission or like any other. It's mostly Dexcom to allow for monitoring. I've given some Libres to my type 2s, basically a continuous glucose monitor so that we can continuously monitor. And when they kind of reach out, like the first few days after, because I'm having a patient a week or so, I try to not just say, make this change, but explain why I'm making those changes. So it's kind of like slow learning process that, hey, this is an imperfect disease. We do our best. We try to come up with a certain dose, but if it doesn't work out, doesn't mean that you're doing anything wrong. This is the nature of diabetes, and let's try to kind of work on improving it all the time.
You're teaching them the way you learned from your fellows.
Correct.
Okay. And you're taking the experience that you had at diabetes camp.
Correct.
For yourself, remembering that you didn't know anything and you had to go over and over and over again until it started to make sense to you. So you're just doing what worked for you.
Correct.
For them.
So, yes.
Gotcha.
So I was like, okay, they're very worried initially about a high number. I always say, hey, it was much higher just a week or two ago when it was running at a super high levels. We did not know diabetes was a thing, but now we know it, we can see it, we have the tools to respond to it. And so
yes,
it's always those kind of questions. Can we have a snack after we had a meal? Or I always try to not give concrete answers, but always try to reference, hey, my gauge is your numbers, and this is what I want to try to kind of perfect. And so my focus is, yes, you need to learn how to perform those skills, how to use a carb ratio. But eventually, if we do the math and the numbers are not where they need to be, we need to think about how can we make it better the next day. So kind of make it like a process and not you do this and we'll fix it kind of thing.
I think that one of the nicest things I heard you say was that what you tell them in the beginning becomes this unshakable truth. So then you know, too, that if you lead them in the wrong way in the beginning, it's hard to break them free from that as well.
Right. And I look at it just like I'm building a house. I need to set up a solid foundation.
Yeah.
And how do I mean, again, this is what makes a diabetes doctor different from like, say, a hematologist, like an oncology doctor, where you're setting up all the plans, for example, for treatment of a tumor, mostly in the hospital. I mean, our jobs is to empower people to do the tasks of diabetes at home. And that's what makes our job much more, again, demanding. And what we're asking for is something that is very demanding, 24/7, 365 kind of job. So this is, I think, what makes it all
It's also very uncommon in healthcare. Far too often, we accept the blood glucose meter that someone hands to us. The doctor reaches into a drawer and goes, here, take this one. Is that the one you want? Is it accurate? You have no way of knowing. But if you want accuracy and you want to be confident in the blood glucose readings that you're getting from your meter, you want the Contour NextGen. It's incredibly easy to get the same meter that Arden uses. Just go to contournext.com/juicebox. That's all you have to do. The Contour NextGen is easy to use and highly accurate. It features a smart light that provides a simple understanding of your blood glucose levels. And, of course, second chance sampling technology that can help you to save money with fewer wasted strips. contournext.com/juicebox. This episode of the Juicebox Podcast is sponsored by the Eversense CGM. EversenseCGM.com/juicebox. The Eversense CGM is the only long-term CGM with 6 months of real-time glucose readings, giving you more convenience, confidence, and flexibility. And you didn't hear me wrong. I didn't say 14 days. I said 6 months. So if you're tired of changing your CGM sensor every week, you're tired of it falling off or the adhesive not lasting as long as it should or the sensor failing before the time is up, if you're tired of all that, you really owe it to yourself to try the Eversense CGM. EversenseCGM.com/juicebox. I'm here to tell you that if the hassle of changing your sensors multiple times a month is just more than you want to deal with, if you're tired of things falling off and not sticking or sticking too much or having to carry around a whole bunch of extra supplies in case something does fall off, then taking a few minutes to check out EversenseCGM.com/juicebox might be the right thing for you. When you use my link, you're supporting the production of the podcast and helping to keep it free and plentiful. EversenseCGM.com/juicebox.
Right.
Because usually things are measured. Take the pill at 1 o'clock, take it at 5 o'clock. I want you to do the albuterol before you have this happen. Like it's all very structured. Diabetes isn't like that at all. Diabetes, it is, but it doesn't feel like it. It feels like it's always flowing and moving and changing. And I need you to do this all at home and make changes too. So how long until you empower them to make dosing decisions that are different from what you've written down?
Oh, it's like a few weeks down the line.
Okay.
So I think because I'm with them pretty much every day or every other day when they leave the hospital. And so it's a lot of hand holding initially, but then slowly they realize what I would do. And then I start to ask questions in the Socratic manner and be like, okay, they would reach out. We're having lows when we're entering that honeymoon phase. And it's like, okay, you see those lows. What do you think caused it? And what insulin change do you want to do? And I always say, this is purely educational. Even if you don't know the answer or if you answer the wrong question, it's okay. And I'll then put in my recommendation myself. Or if I see that they put in a recommendation and it really is what I would suggest. And I was like, okay, yes, this is what I want.
This is how I do it online. When I talk to people, I'll almost always say to them some version of what do you think? Or you ask them a question to get them to think in a direction that they don't know to go into. Have you ever done that kind of lead, like little carrot and stick, lead them towards it?
Oh, yes, absolutely.
Yeah,
absolutely. Yeah. And sometimes I say, okay, I usually go down. I mean, sometimes when I see somebody is just really stuck and frustrated, I'll say, okay, we'll do a 20% decrease. What do you think that will do? So at least I'll make them do one task out of the process.
Yeah.
So at least getting them engaged in there, it's more of where's the center of control. I want it to be with the families. I want them to feel that they're under control of their disease. Yes, they get their prescriptions and the guidance from the doctor's office, but it's mostly I want to empower them to really be able to be independent in taking care of that disease. So they don't need a doctor's input a lot down the line.
Right. It becomes crippling. If you infantilize them and don't let them make decisions, then down the road when you're not as connected any longer, they don't know what to do. And then they just start taking those outcomes as this is how it's supposed to be. And so they don't even reach for more at that point. They just accept it.
Right.
Yeah.
And honestly, I feel that my personal anecdotal experience in my practice or care model is that I really, really value starting a sensor day one and having that hand-holding process throughout, because it's a very critical moment. This is when they're very eager to learn. And this is when I can really get somebody to get a buy-in with me teaching versus if somebody's had diabetes for 5 or 6 years, I might teach the exact same skills. It might not stick because this is not what they've been used to. It's very hard to change someone's behavior once we get to that level.
Yeah. So that's insurance though, right? If they have insurance, then they get one. If they have, but are there people who you want to put on them that you can't get them for?
Pretty much. At least in Maryland, I know other states might have it differently, but in Maryland, it's universally covered for anyone who needs insulin 4 times a day.
Oh, wow.
So I have samples in my office that I give at the hospital. And so the first one is just a free sample. And that buys me 10, 14 days until I figure out a prescription and a prior auth. But pretty much they're getting continuous numbers since they are in the hospital for that first appointment.
Do you see people becoming overloaded with data, or do they handle it well?
People handle it differently, but I feel that I want them to be overloaded with data. That's the whole point, is to let them know diabetes is messy and let's try to sort this together, and trying to just walk them through my thought process about making it less of a messy disease, so to speak.
I appreciate that attitude. I really do, because I think that everyone should leave the hospital with a CGM.
Right.
Yeah, after diagnosis. It's just so valuable. And you learn so much about how food and insulin impacts things. It makes you just ultra aware of all the things that would look completely invisible and unknowable if you didn't see the data.
Correct.
Yeah, it's fantastic.
I honestly, again, this is kind of the part. I'm sure that down the line we'll have more studies to support that. But I think at this point, even without a study, I think I already know that this is the route that probably the future will see this model get more generalizable. Right now, I have a very busy clinic, 8 clinics a week. I really don't have time to kind of sit down for academia and research. And an important topic to kind of just review, evaluate, not in terms of control, because I think if we're just studying control in a month or two, I don't think that's a good outcome, because I think eventually Mother Nature allows honeymoon to kick in and everybody gets a relatively good A1C in like a few weeks, a few months down the line.
Some stability happens. And
a year down the line or 2 years down the line, the understanding, the level of being able to handle the burden of diabetes. Initially, I had a mom who was very, very worried about how discrepant the numbers are between the Dexcom and the glucose levels. And she was almost going to write off a Dexcom in the hospital. But then I was like, okay, we need to be patient with this. This is a tool. So it was more of the explanation. But eventually now she's like, Dr. Marwa, thank you so much for walking us through it, because otherwise we might have not even started it. And I've had it here now where I have a patient who is 7 years into their diagnosis, they are still refusing to wear a CGM because they had one bad experience. So I think if we just say that this is the way, this is the standard of care is to take care of diabetes with a CGM despite its limitations. And let's walk through it and let's teach you a sugar stick as a backup. I think this is the message that I want them to stick with, and not the fact that, oh, I can take care of diabetes with finger pricks. Yes, you can, but you're not going to get the good control that you would get otherwise with a continuous glucose monitor.
What do you think about the algorithms? Do you put algorithms on people?
So algorithms, do you mean DIY systems?
No, well, all of them. Omnipod 5, Control IQ, Medtronic 780G. Like, do you give those to people?
Oh, absolutely, yes.
Yeah.
That's what I do most of my day is I look at most of my days IT tech support, so to speak, because, hey, we need to connect them and we need to look at their numbers. The algorithms, day one, I tell them, this is basal bolus. This is how we're going to do it in the hospital. It's a backup system, but yet you need to learn. But I always introduce to families that, listen, it's just a transient phase, but most of my kids will need to transition to a pump process of some sort to get the good control. So I always say this is just a stage to learn. I kind of try to give the analogy of a elementary school student. We don't give them calculators until they have mastered how to do addition and subtraction on paper. So I always put them in the mindset that this disease requires technology to fix it at this point. We can only do so much with shots. Eventually, the goal is to transition them to a pump of some sort, of a closed loop system.
So you're of the opinion that they should know how to use a manual pump first?
Not a manual pump, but at least know how to master injections first. A lot of families ask me in the hospital, can you get a pump right now? And I was like, no, it's mostly educational. I mean, if they already had another sibling on a pump and family has gone through the process of training, then yes, I don't mind a pump week 1 or 2 after diagnosis.
I was going to ask you, can you dig down into that a little bit for me? Tell me what the benefits are that you see coming from being MDI for a while.
Oh, so I think understanding the process of diabetes, understanding the relationship between insulin and food. Yes, we can also get that in a pump, but I think with shots, it'll make more of like you are actually getting that insulin to see the effect of food. But then eventually, I think with any pump, there is a chance of technology failure. So I don't want them to be very overwhelmed when technology fails and we have to resort to some sort of either manual mode or MDI.
I see. If you could be certain that there wouldn't be any bad sites or mechanical, hiccups, then would you have any trouble with them starting on a pump then?
The family knows how to revert to MDI. I wouldn't mind that.
Okay.
Meaning the family should be very well versed with MDI. They should not, it's not like, oh, we just learned about it for a day in a hospital. No, they should have really a full understanding of this is how you do the long lasting, this is how you do your rapid, and this is how we calculate the doses manually. It will help them understand how we think about insulin doses. Yes, I do prescribe the bionic pancreas. Against prescribing it that first week of diagnosis, I think it's important to understand how insulin works and to see, okay, what does 5 units mean to my child, to my meal, and what it does, and how different doses deal with it. Like, again, how they affect insulin levels. Like, just make it more of an understanding and break the barrier of, oh, diabetes is difficult. And then I want them to feel that, oh, diabetes is not too difficult. And we really know, and it's only repetitive. And I think this is when somebody's ready for an upgrade. And this is why it's like, at least I give them a few weeks of MDI.
Do you have an example of something that you've seen go wrong when someone starts off without that understanding?
I started, I've had that parent who was so much into technology and they requested an InPen. An InPen is a smart pen that would have a bolus calculator and would tell me, okay, how much you program the carb ratios, the correction factor, and the pen will calculate the insulin on board, pretty much like a very old school bolus wizard,
Right.
and will log in the insulin doses. So I had a pen who requested that day one in the hospital, and I was able to actually provide an InPen as part of their discharge prescriptions.
Mm-hmm.
I think the problem that happened is that they became so dependent on that recommendation of the pen, thinking that this is an absolute recommendation, and it kind of made them not think about how good is this dose working, or is it time for me to make a dose change? Mm-hmm. And so they would be like, okay, that's what the pump recommended. Sorry, that's what the pen recommended. That's why we gave it. And not really that, okay, no, this is something that's man-made, that we came up with those programming settings and we need to continue changing it, kind of thing.
So is it a situation where once it's given over to the pump, that if they see if they see a situation that doesn't react the way they expect it to, they don't think about it any more deeply because they believe that the pump has told them the right thing to do?
Oh, it happens all the time, yes.
I see.
This is where I would like people to think beyond just what's happening. And unfortunately, that might sometimes lead to DKA because, hey, the pump told us to not give anything when the pump was actually kinked or something, and someone might try pushing in insulin, and despite you reading HI for many, many, many hours, and then the kid just comes to the emergency room with a DKA diagnosis.
I see.
So I try to kind of prevent that reliance on technology, and I try to say it's not a foolproof thing. Your foolproof is you need to know how to do the shots right. I need you to know how to give insulin manually and how to be able to just put a pause on diabetes technology if you need to.
Okay. Very nice. I appreciate you explaining all that.
Oh, of course.
Yeah, no, it's fascinating. So I guess my question is, you said you teach people how to do their jobs now. Like, so you've now become a person who helps younger doctors learn what to do and what to expect.
Right.
What do you think are some of the most important lessons that they can learn when they're younger, those doctors?
All right. So I think just being humble to diabetes and learn from your patients, because my patients teach me something every single day. Like, there's always a new trick or hack that I did not know about, whether it's in technology and how they do things. I've found really, yes, I learned a lot from my teachers and my mentors and my professors, but my patients, I'm very, very grateful for all the discussions and the interactions we've had together. I think that's the number one thing, is be humble and understand that what it is that we're dealing with every day, what we study in textbook is really nowhere close to what people with diabetes and their families have to deal with every day.
Right.
And again, I think my other advice would be to not prejudge a patient or a family. I think a lot of doctors fall into the trap of they judge a diabetic based on their A1C or their rates of admission for DKA. I think sometimes we as doctors need to step back and look at the full holistic picture of what's happening, what are the barriers to care. Don't look at it as sometimes people used to, as from the doctor's world, label patients as non-compliant and just call it a day. And I think this is the easy, lazy way to do things. I would say they're not adherent to the plan of care. What are the barriers? And let's break down those barriers.
Yeah.
And so this is the process that I try to teach all my training doctors who come here to, like, okay, their A1C is high this time. What are the barriers? And let's try to kind of break them one by one and try to hopefully work on making it better the next time. Whether it is an educational barrier, a technology barrier, supply barrier, insurance barrier, no matter what barriers there are, I always say, hey, Mother Nature's plan for this kid is to have their A1C at 17% or higher. So whatever number that's lower, there's some work that had been done. And I always celebrate the successes and try to kind of work on improving it the next time.
Oh, that's excellent. What percentage of their students do you think learn those lessons? How many out of 10 do we send off into the world to be good, thoughtful, quality endocrinologists? And how many of them just end up writing down non-compliant if they don't get the result they want back?
So right now in my capacity, I'm training general pediatricians. So I'll be very honest, I'm not training actual endocrine fellows who are about to be endocrinologists, but I'm trying to teach general pediatricians if they see their kids with diabetes, whether in the emergency room, a hospital, or their outpatient clinics, kind of what to look for and kind of how to approach a high A1C in that scenario.
Mm-hmm. So that's not a fair question for you then on that form. But let me ask you this then. How do we get the overall quality that people see? Like, I mean, this is happening at your hospital and, at your facility, but that doesn't mean it happens everywhere. Like, how do you think we can turn endocrinology into something for type 1s that is very specific to them, instead of, what often happens to adults, for example, is that they end up at an endo that handles mostly type 2 and they don't know anything about type 1 and they get no direction whatsoever. Like I know it's a thing you have to learn. And I know it's not the same as being other kinds of doctors where there's just rules or, when we take the medication or when we put in the implant or something like that. Have you thought about that? Have you thought about ways to spread good care to type 1s?
That's a very good question, because honestly, even my care model, I could not even, I would say, share it among peer endocrinologists in my surroundings. So not everybody is hardwired to kind of function this way, so to speak, because endocrinology is very algorithmic, so to speak. I mean, you have low levels of thyroid, you give thyroid medicines, you check labs in 2 months. So I think if we put diabetes into that umbrella, this is where a wrong thing happened. And this is where it's very, very hard, because we're all, doctors are humans at the end of the day, right. And we are just as varied as, again, the variation of human nature. Some people are more patient than others. Some people are more rushed than others. Some people like to rush through things. But I think if we're looking at it from a systematic standpoint, then yes, we do have a lot of potential in terms of educating, again, endocrinologists about type 1 diabetes when they're in their fellowship, but also actually, I think, and this is what I always tell my families, is that they can share some information with their own doctors about, hey, this is something that I'm interested in. And the doctor needs to also explore those things and needs to be very honest if that's something that they do every day or not. And I'll be very honest, not every endocrinologist is fit to handle type 1 diabetes. Again, some people, that's not their thing, and they shouldn't be forced into that field. You should have a passion for a topic if you really would like to take care of it.
Right.
I find it hard to answer that question because, again, it goes into a lot of political.
No. I expected your answer. I just wanted you to say it. That's all. Because it is random. Like, there are people who will just luck of the draw get you, and there are people who luck of the draw will get somebody who's not well suited for it, and right. And then their health follows that path and they don't even know. Like, that's the part that I think heartbreaking to me, is that I could have got you, but I got somebody else, and now my A1C is 7 instead of 5, and I'll never know that my whole life. I'll just think that I went to the doctor, they told me the right thing, and a 7's what I'm able to accomplish. And,
right.
It makes me wonder so much if we're not going to see a significant change in this through, I don't know, AI, honestly, over the next 10 years. Like, how soon until AI is connected to your CGM data and it knows how many carbs you've taken and it starts making suggestions to you about, hey, I think we should change the carb ratio to this, or I think we should change your insulin sensitivity to that. Like, that stuff can't be that far off.
Right. And I think we're already in the bionic pancreas era.
Mm-hmm.
Just to give you a little perspective, I've had a lot of patients who everyone was like, okay, my normal A1C is 9-10. And I was like, this is not normal.
Right.
And so, especially in lower, like, underprivileged communities, and this is most of the kids that I serve here are from underprivileged community, Medicaid, mostly government insurance population, and for pediatrics. And like you said, they don't know any better about, oh, really? There is a pump that can do that? And so a lot of doctors would put themselves as basically the judges of how good someone is. And they would think of a pump as a prize, as like, no, it's a tool. I would give, for my criteria to start a pump are very, very low, meaning you just have to have type 1 diabetes and you have to care a little bit about getting it better. Like, you need to charge any pump, you need to keep it on your skin, you cannot just disconnect it. Yeah. You need to have somewhat of a caring thing about your pump. So now to your question about AI and technologies. So I always think about that every single day is like, when can I play offense and not defense to diabetes?
Mm-hmm.
If I see somebody in the hospital in DKA and they're wearing a Dexcom, you don't know how many times I looked at a Dexcom where it was reading 380, 390 for like many days. And we are looking at that data. Of course, nobody alerted us to look at it. Otherwise, we would have guided the families on what they need to do.
Mm-hmm.
But we wait until they land in our emergency room when they are very sick, when we could have kind of picked on those early signs of a deteriorating disease early on. I think it would be interesting to see what the future would hold in terms of not just the carb ratios. I think this is a very advanced thing, but at least there's something going off and you're spending time in the 400s. Maybe it's time to alert the doctor. We don't even have that as an option in most of those data analytic softwares that we currently utilize. So there is no way for me to sort which kids, so to speak, need my help. And unfortunately, some kids go into a mental health crisis and then diabetes control goes south. And I wouldn't know. And these would be the kids that I would expect poor control from them the least, because again, typically it's something outside of medicine. It's not that they don't have a medication. It's mostly something social that impacted their diabetes management.
How often do you see people with a 380 for days that they don't do anything about? And what do you think that causes them not to react?
People just become numb to just, hey, we're used to being numbers, like the numbers this high. It's like, and this is what I mean. It's like people were not taught the targets they want. They don't know what to expect. And some people just treat diabetes symptomatically. I don't feel bad. I feel okay. I don't care what my numbers are.
Mm-hmm.
This is the struggle that I always try to make them care. I always say I need to make the highs are painless, but I need to make it painful. I need to make them feel that this is not right for my body. And so I think a lot of times there is a fear of dropping low. There is like, okay, we're not even checking. They're not having the alarm set, or nobody's actually looking at that data until they see me in clinic.
Right. So for the group of people who are not scared of being low, they're just not motivated.
Right.
Do you think they don't understand the impacts on their health? Do you think they don't care? From my perspective, as a person who sees a 135 blood sugar and thinks, I think we could bring that down. I don't understand staring at a 380 for days, but I'm trying to put myself into the mindset of a person, because it's not just apathy, right? It's not that they don't care. Like, there's other things at play.
Right. And I think it's that invisibility feeling that, okay, you know what? I mean, nothing is going to happen to me. Even if I go into DKA, I know that the doctor will fix it for me, kind of thing. So it's especially, again, I'm a pediatric person, so I deal with a lot of children and young adults. I mean, children don't think the way we think of things. Like, I wouldn't expect a 16-year-old to think about a 401k. So,
right. But their parents don't get involved either? Did they do that thing where they're like, I tried, I told them, but they don't listen?
Yes, all the time. Again, it's more of, we gave them the tool, we bring them to the doctor's appointments, we try our best, but we also have to work 3 kind of jobs, and I cannot be there with it to baby my child
Constantly.
anymore.
Yeah, I see the problem. Okay.
So this is kind of the struggle that I have to kind of deal with. And this is where I think AI, like on the spot, and this is where, honestly, again, sometimes even an Omnipod 5 algorithm might really not work for that person. So I honestly took a lot of people out of Omnipod 5 into some other pump, and vice versa. I've taken some people to the Omnipod 5. Some people would do better with a tube. Some people would do better without a tube. Some people would really like that, hey, we did something different about what we're dealing with every day. And I mean, I've had a kid who really did not pay attention to the Omnipod 5, and then the Omnipod 5 will go into manual mode because it's reached its automated delivery settings. I switched him to a bionic pancreas, and today I saw not great results because the kid was not connected to their pump most of the night. So again, this is the kind of I think, yes, there is a role for technology, but I think we are at a decent stage from a technology standpoint. It's more the psychology and having the buy-in from the people living with diabetes to say, no, I really want to feel better. I really want to make sure that my numbers are better. I mean, that might sound like common sense to us adults, but for a lot of my kids,
it's not.
And some kids do, but some kids or some adolescents, it is a struggle for them dealing with the Ds. They'd rather not think about it or just hey, as long as I'm okay, I'm not in the hospital, I reached my goal. So I try to be patient, I try to take it step by step. I try to kind of go focus on little goals and actionable things that they can do to try to kind of prevent a, so to speak, like a major relapse in diabetes, like a DKA admission, but also to really make sure that we're back to the process of, hey, you need to be seeing 100 most of the time and not 250, and you feel that this is okay. And so trying to change that mindset is a hard thing. I think, again, I'm not a behavioral person myself, but my wife does a lot of work with applied behavioral analysis. My father is a psychiatrist. So again, I was surrounded by a lot of mental health experts in my home. So I got a lot of training there about maybe a behavior prescription, so to speak, kind of thing, which I think is helpful.
Yeah, no, I would imagine it would be greatly valuable. Can I ask you, so I find myself like wondering out loud about the iLet pump, the Beta Bionics pump. And I think, well, if somebody's not going to do anything, at least if you put them on that, they maybe could get an A1C in the 7s with it. But you're telling me that you might be intersecting people who won't put the pump on even.
Right. Yes. I mean, not put a pump on for quite some time. And again, of course, the usual, I'm not getting my shipment from my supplier. It's like the usual frustration. And then, okay, we don't know what to do as a backup and then our numbers are just running very, very high. So I think, again, until there is a biologic fix to type 1 diabetes, which I'm hoping for will happen in the next hopeful decade or two. But and so until we're there, I don't think technology by itself helps
everybody,
can fix diabetes. I think there should be also a lot of work on the psychology and the social work services that we provide, and not social work in terms of, I don't want someone holding a stick. One time I called a social worker and told the mother, if you don't follow this plan, we'll take the child away from you. I mean, it should not be confrontational. Some social workers just don't understand the complexities of this disease, and they want to try to get a black and white answer. And there are lots of shades of gray. And there are there's this difference between somebody who's just overwhelmed, frustrated, diabetes fatigued versus somebody who really is completely negligent of their child. And that's a fine line. And I always find myself thinking about those things. But at least if I have somebody who reaches out to me when they have a trouble, and then we have that open line of communication, and we're able to really, again, it's a partnership. It's like trying to get to a place where they're in harmony with their disease. And what I mean by harmony is that they're doing something that they're comfortable doing, and they're seeing the results that they're seeing. I mean, you would be surprised how many times I would read somebody with an A1C of 12% and ask how things are going, and they feel like things are okay.
Yeah.
But in my mind, things are not okay. We need to fix things.
Wow. You're dealing with so many different types of people and situations on top of that. Anywhere from someone who's very interested and able for a number of reasons and is probably keeping an A1C in the 5s to somebody who you're just like, look, you have to put the pump on or you're going to end up in the hospital.
Right.
And everywhere in between. And parents that can be involved and parents that can't be involved, and kids that do care and ones that don't care. That's exhausting, no?
It is very exhausting, yes.
Yeah.
I love the experience of it all. Whether it's somebody that I was able to, again, at least move the needle in the right direction, and trying to at least make them leave the office with a positive attitude about, yes, I can handle this. Yes, I can. This is something that I learned from the doctor. I can hopefully make this better the next time, and just celebrate the little victories as we go.
Do you have any luck explaining to people that high blood sugars lead to cloudy thinking, that they are sluggish and generally less healthy, and they wouldn't even know it at this point? They don't care?
So I deal a lot with kids who are taken care of by caregivers. And so a lot of times I tell the parents, please, for the next few weeks, you need to take away all their independence privileges, and you need to be on charge. Not all your life, but give me a week of very solid control. Otherwise, your kid will land at the hospital.
Right.
So, I mean, at least I try to make such an advice very indirect, but at the same time, very actionable, to say, hey, listen, it's like they're sick and they don't understand that they're sick. Like we need to do A, B, C, D. You need to follow it as a protocol. And just remember the day you left the hospital, you were calling us every day or every 2 days. We have to kind of push a hard reset button on diabetes and get it there. Otherwise, I'll have to do this for you in a hospital setting.
Right.
And so a lot of times I was able to, so to speak, press a hard reset on diabetes.
How often do you experience someone who has struggled like this, but eventually just breaks out of it? Like, do you see them come around eventually?
Yes, all the time. And this is what makes it very, very fruitful. I mean, I've had people, both type 1 and type 2, who had very difficult diseases. Sometimes it's just giving them the right tool, and sometimes just listening to them. Sometimes it's empowering them, and seeing a lot of people who just, again, previous endocrinologists would always be like, okay, non-compliant, you're stuck in the 10, 11% A1Cs. But I think I see a nice slow decline because like they feel that they are now empowered to really do this. And they find that, okay, it's not that bad to follow the doctor's advice. I don't have to be defiant as a teenager. The doctors might say something that's going to help me. And so trying to kind of work with them and not kind of be their dictator, kind of like, I'm not mandating you to do this, but hey, why don't we do this and try to make it something that, like I use a lot of salesperson tactic. Let me put it this way. And I try to not celebrate victories very early because a lot of times I see a sharp decline, but then things might go south socially and then I might see a spike back up. So there is no finish line in diabetes. It's always, how can I make it better so that the following time we can continue where we are.
Right.
So even for my kids who have very good control, my appointments are still very long because I like them to stay in that range and not really rebound.
Yeah, not to feel like, oh, I did it, now I can stop doing it.
Right.
Right. How often do you find yourself without hope for somebody?
I mean, I think when I feel that the person is not connecting with me, I tell them, listen, maybe I'm not the right fit for you. Maybe you need another endocrinologist. I mean, I can't force people to like me, it's just, but if I feel that I cannot partner with someone, when I feel that there are barriers I take a lot of no-shows. People can sometimes not show up to an appointment. It's fine. I'll try to accommodate another time. But if somebody has not seen me for a year and a half, I put a hard stop and say, you need to see a doctor, or otherwise I cannot keep on being your insulin dispensing machine. So that was my hard stop. But otherwise, pretty much, I try to not give up on someone, because if I do, then I know that, knowing my colleagues in the field, I don't know if someone else will be able to provide them the care and just the hand-holding that I might be able to provide. But again, I would like to give them the option and eventually to really be able to self-manage so they don't need the doctor. So yes, I have patients that I need to see every 2 weeks or every week, to patients that I can see every 6 months. And I had somebody who canceled that 6-month appointment, and a year later, the A1C was still 6%. So back to my question is like, what's the role of a doctor? It's like, yes, we are the educators, we're the coaches, we're the guides, but we are basically the captains of the ships. We need to make sure that things are getting in the right direction.
Have you imagined a magic wand fix for problems like this yet? Like, do you look at people and think, if I could just make them believe, do, feel something, that this would all go the right way? Like, do you know the path and you just can't get them on it? Are you not certain of what the path is at times as well?
Sometimes I'm not, because especially if it's a complex social disease. So say if somebody's struggling with major depression and diabetes, it's very hard for me to fix that without true mental health help. And I don't have a psychologist or a social worker in my office. So I try to be the social worker, even though I'm not a trained social worker. I try to be the psychologist, even though I'm not a psychologist. I try to, not a psychologist in a professional setting, but in a way, so to speak, good heart, somebody who listens to them and try to acknowledge what they're going through and try to, at least in a way, be neutral through what they're going through and be a, so to speak, diabetes mechanic. My focus here is diabetes and not a mental health professional.
Right.
My focus here is, hey, yes, you're going through a lot, but what are the things that you can do for your diabetes so that as a diabetes guard, your diabetes is not going out of nowhere. I mean, whether you're having a good day or a bad day, your number should not have a bad day. that's my mantra there. I would like to make a good day for diabetes, no matter what the psychology is. And this is where technology really helps in that regard. If somebody's into that habit, into that routine, then no matter what life brings, good days or bad days, will have a good control of their diabetes.
So, yes, we can see people be like, I guess, emotionally overmatched by it. How often do you see people who are intellectually overmatched by it? And what do you do about that?
So is it more that they feel that they're defeated by their numbers and diabetes, and that it's hard for them to kind of predict what's going to happen?
I mean, I'm saying, are there people who just IQ wise just can't keep up with what's going on? They can't juggle all the balls and understand the math. Yeah.
I've had a few families, and again, this is where there is no magic wand. You have to take it step by step and focus on one tool and work with it. I mean, I've had a toddler with diabetes recently, and it was a very big shock for them to have to deal with diabetes every day. Initially, because the kid was not eating solids, so I did not need to teach carb counting initially. I needed to just teach, this is how much you're feeding, this is how much insulin you need to give for that amount of milk the kid is having.
Right.
And then slowly introduce carb counting, slowly introduce ratios. And so I'm thinking maybe this kid, I'll put it on a bionic pancreas because I don't know if they'll grasp insulin in a toddler. But again, I want them to understand that any device can fail or cannot give insulin. If the numbers are high, we need to do something about it. Unfortunately, this kid is averaging 350 and they're very sensitive to insulin. And if they get insulin, they go very low. So it's a very, very hard balance.
Oh, gosh. Wow. It's just a terrible thing to have to deal with for sure.
Yeah. Yeah. So.
My gosh. Well, I'm going to put this episode in with my series called Grand Rounds that I've been making this year, where myself and a CDE who has had type 1 diabetes for 35 years, we took people's feedback, listeners' feedback about what they wish their doctors would understand. And we did episodes about that. And now I'm adding on conversations with doctors about how they work in endocrinology. So I can't tell you how grateful I am for you taking the time to do this.
Oh, of course. No, thank you so much for giving me that podium, that platform, because yes, I heard about the Juicebox podcast. I think I've listened to one or two a few years ago, but I'm very, very grateful to be here today.
No, I'm very grateful for you taking the time because I'm very interested in this entire dynamic about, different people, different scenarios, different variables, different doctors, and how do we get as many people as possible to lower stable A1Cs that allow them to go live their life and not think about diabetes quite so much. If you listen to some people, they'll just say, my doctor sucks. And I'm sure some of them do. But I also think that there's, I don't want to say culpability, but there's responsibility on both sides.
Right.
And oftentimes the doctors don't know when they're falling short and the patients don't know when they're falling short. And they're very apt to blame each other in that scenario. And I don't think it's that simple.
And this is where I feel that, hey, I mean, if it doesn't work out, maybe it's not a good fit. I mean, I've had some of my colleagues who are very, I would say, robotic in the way they approach diabetes, where it's just numbers. I mean, some people just want that kind of doctor, Yeah. It's like, make sure that my numbers and my pump settings are okay, and I'll take care of the rest. And these are typically parents who or families who are already pharmacists or medical professionals or highly educated people. But that does not capture the majority of people who's living with type 1 diabetes every day.
How progressive are you with other things? Do you aggressively manage people's thyroids, for example?
Oh, yes, absolutely.
Yeah.
I mean, I think once I have a problem, I try, it's all in or all out. That's my style.
You medicate symptoms, not numbers?
Pretty much, yes. I take numbers into context for sure.
Sure.
I mean, of course, our numbers, I mean, if numbers don't make sense, or if I feel that a medication won't really help, then I'm
You're not going to use it just to use it.
I'm not going to use it.
Right. But if you're symptomatic and you have a 3 TSH, then you're getting Synthroid, for example.
I don't think so. No, I think at least a higher number. So depending on what again, I try to be logical and try to see, hey, I always tell my families, I'm like a hormone judge. Is the thyroid guilty or not guilty? Is the pancreas guilty or not guilty? And then I have to kind of give back whatever hormones the body's missing.
Mm-hmm. Once you're confident that it's thyroid, what are your TSH goals?
Oh, just in the target goal. So say if it's in the reference range for a lab, then I'll take it. But of course, if somebody is symptomatic and there is room to increase the dose, I don't mind going up on the dose.
Very nice.
And keeping it a trial and error. But I mean, typically teaching is TSH of 10 or higher is what you treat. If somebody who's not known to have thyroid disease. However, I've had someone that I treated as 7 or 8 because they had some symptoms. And I thought, you know what, it's very plausible that those symptoms might be contributing. Let's give it a try. It kind of helped the symptoms, the constipation, but it now made the kid is now irritable. So I'm not sure what to tease apart. So I think it's not a straightforward, straight line of thinking. It's more of, it's a tool. I mean, medications, hormones are out there are tools for us. And
certainly,
if we could utilize them to really improve someone's health,
then do so.
Yeah. Let's do it. Yeah.
Can I ask you, when you do blood work for people, do you look at their iron, ferritin levels, things like that?
Not typically for type 1, unless if someone has specific like symptoms or they have anemia, I would.
Okay.
But not my typical screening. I typically follow the ADA screening guidelines to the book from that regard.
I asked and I wonder because I feel like I see a lot of people with digestion and then absorption issues. So once you have like type 1 or autoimmune, you can see poor digestion in a lot of people. Like you must have kids that are like, my stomach always hurts, stuff like that. And then, we've been having a lot of conversations on the podcast with people using different aids like digestive enzymes and things like that have been taking away a lot of that pain, where their endocrinologist will sometimes tell them, well, you have gastroparesis. And it turns out that maybe they've just needed some help with the digestion process. And when that digestion gets messed up, oftentimes the nutrition uptake gets messed up along with it. And then I'm seeing a lot of people with low ferritin issues who have type 1. I see a lot of different interesting connections having so many conversations. I have over 1,200 episodes that I've recorded over the years. And for instance, to talk to people and say, hey, what other autoimmune do you have in your family? And as I'm asking them, I'll always say, how about bipolar? Do you see a lot of bipolar? And you'd be surprised how many people have a bipolar relative when there's autoimmune or type 1 in their family. Little stuff you would never see connection to if you didn't have the opportunity to ask so many different people.
Right. Yeah. So, no, I mean, I'm very, very grateful for all those things. Again, this is I think this is how this is what sparks science and scientific research is like, okay, you look at a connection and then we kind of put it to the test with a scientific research question. And I think there's a lot to be understood. There's a lot we need to learn about what causes type 1 diabetes, what might be a link with other digestive or autoimmune disorders. And I'm sure there are a lot of unanswered questions that we'll continue learning. I mean, we already have achieved a lot, but there's still a lot to learn about diabetes and what's happening.
I'm excited that people like you were involved. Can I ask a question?
Of course.
What do you think, or have you thought about where we're going to see GLP medications used with type 1s in the future?
So I am a very aggressive user of GLP in type 1, probably more than my other colleagues in the field. I feel that if someone has signs of insulin resistance and their insulin daily requirements are much higher, and there is that family history of type 2 diabetes, I think they have two diseases. They have both type 1 and type 2 diabetes for the same person. I have, especially for my kids who have type 1 diabetes and who are overweight and who need, for example, 150 units a day. Should I just give you more insulin? Yes, I need to give you more insulin. But I always ask myself, why do you need 150 units a day? And these are the kids who end up typically getting a GLP-1 prescription along with their insulin type 1 treatment therapies. So in terms of, I think, the question about a GLP-1 for people who don't fit this umbrella, for people who are type 1, they're not overweight, there's no family history of type 2, can we give a low dose of GLP-1 to kind of help just with some endocrine function. I have wrote it up with one or two patients who were in honeymoon and they wanted to think about, hey, can we prolong honeymoon this way? I'm not sure if you're aware, but the New England Journal of Medicine submitted, there was a research that was published of a small clinical study, only 12 participants who had longer honeymoon, longer C-peptide if they took a small dose of semaglutide, much lower even than the dose that I would start somebody with type 2. So for type 1, can I give them a small dose of a GLP-1 agonist to kind of help preserve some pancreatic function, especially if they're in that honeymoon phase? I think this is a question for science to answer in a few years. I feel that I look at GLP agonists as, in a way, getting the effects of exercise into the blood sugar level, but without actually exercising. It's nice how their insulin requirements would come down and diabetes will be an easier disease to manage with those medications. Plus also the impact of the effect of appetite and lowering the appetite might also impact and improve those glucose levels.
The study you spoke about, do you happen to know, was Paresh Dandona involved in that one?
Let me pull it up really quickly.
Because I'm about to have him on the show. And I've had the mother of a 13-year-old child who's had type 1 for 3 years more, using 70 units a day, but with a background in the family of PCOS. And they gave the child Wegovy, and they're down to 7 units a day, and they're not even shooting bolus insulin anymore. Yeah.
I think there's a lot of potential. I think we are going now. I think the biggest barrier for me prescribing it off label a lot is insurance. They come in.
Yeah.
But for example, I think if somebody is overweight and using a lot of insulin units a day, I've been able to convince insurance to start them.
Have you? Yeah, that's amazing if you're able to get type 1s covered. Because I'm right now, my daughter has PCOS and type 1, and I'm having to buy Ozempic out of Canada just to give her a non-therapeutic dose. And you should see how much it's helping her. It's significant. Her insulin sensitivity went from 1 unit moves her 43 to 1 unit moves her 93.
Wow. So yes, it's Dr. Dandona, Paresh Dandona, and Dr. Chaudhary.
Yeah, I'm in contact with him right now, setting up having him on the show.
Wonderful.
Yeah. No, I'm excited.
So I think my trick there, I would mention that this is an element of type 2 diabetes, and I make it that this is, yes, we have a background of type 1, but please look at the data. It is suggestive of type 2 in the intermix of the picture. Like this is part of what we're seeing right now.
Really?
And so I was able to get insurance buy-in in a lot of, and once I get approval, it's very hard that they come back and deny it again.
Back after that. I have to ask you, if you have any tips and tricks for that, if you'd email them to me, I'd like to share them with my daughter's endocrinologist.
Of course. Yeah. Yes, I can. I think it's with insurance, it's always a game. That's another side of what we have to do behind the scenes to try to make sure that we can write the right things to convince insurers for what we are doing is really sound and medically reasonable and makes sense.
I think there's going to be a lot of application for it. I really do. And there's other stuff coming too, right? Isn't one of the companies is working on a daily pill instead of a weekly injection? I think there's a lot.
Right.
I have to tell you, I don't have type 1, but my daughter does. And I've been using a GLP for a year now. And I would tell you that I've lost 50 pounds in a year, but I was never a poor eater or a person who wasn't moving. And if I had one way to characterize what I think is happening to me, it feels like I have a GLP deficiency, because in the first 4 days on 0.25 of Wegovy, I lost 4 pounds. My digestion changed, like everything. I was a person who would have to get iron infusions all the time because I wasn't absorbing my nutrients. But now I've been on a GLP for a year. My ferritin level is 188 when it was just tested. I haven't had an infusion in like 18 months.
Wonderful. That's great to hear.
Isn't that crazy?
So,
yeah.
It's amazing again how those new medications are out there. I mean, did not speak about type 2, but I also treat a lot of adolescent type 2 diabetes in my clinic. And we see it very, very commonly, much more commonly than when I started like 6-7 years ago. We were seeing an up spike in type 2 diabetes.
Right.
I think when doctors treat type 2 as type 1, this is the wrong thing, because we keep giving them more insulin and we kind of playing catch-22. And so I try to get them out of the insulin cycle by prescribing a GLP-1 agonist for a lot of my kids, especially now that we have a pediatric indication for 3 GLP-1 agonists. And I'm sure that we'll have more choices for pediatrics as we progress.
Yeah, they're working on it in a lot of them. Even for pregnancy, they're looking at it now, like to be able to keep people. Listen, my brother, I'm adopted, so not by blood, but my brother is type 2, and I talked him into pushing for a GLP, and his A1C went from the 7s into the 5s.
Yes. So
that's
again,
really astonishing.
And these are people who've had it for years. So even though my training is in pediatric type 1, or just pediatric endocrinology, I'm now board certified in advanced diabetes management, meaning I can still take care of adults or diabetes across the lifespan. So sometimes I do help some parents with their own diabetes when they ask me questions about diabetes. And so there was that girl who came to see me, again, PCOS, insulin resistance, type 2, and severe obesity. The mother had the same problems, but somebody told the mother that she had type 1 diabetes after she had gestational diabetes because she was very hyperglycemic. And this mother, poor thing, was under the care of her endocrinologist for, again, more than a decade, treated as a type 1. But I counseled her, even though I at that point, it was a very brief interaction. I strongly suggested that she presses for GLP-1. And she went down from needing 150 units from her Tandem down to like 20 units a day of her Tandem.
That's wonderful, isn't it? No, hey, you're a little go-getter, Dr. Marwa. I see all the letters after your name, by the way, here.
Yes,
I see you out there hustling.
I mean, I enjoy taking exams. I don't mind them, but I think I'll... So
your letters are going to be on a different line if you get a couple more of them.
So
it's funny.
I mean, again, I get all those emails like, "Hey, come certified." It's like, "Hey, you know what? Why not? I'll get that." Not that I think it makes me a better doctor or worse doctor, but I think it's nice to show that, hey, to learn, of course, and also to be able to present that, yes, I'm not just an endocrinologist. I also do care about this disease.
Yeah. No, I love your energy around this. I really do. I appreciate this very much. I might have to ask you to come back on again one day. This was wonderful.
Of course. Thank you so much. I will probably be moving to Saudi Arabia.
Oh, okay.
That will be probably like this summer. So my contract here in Baltimore is terminate, like is ending. And so I might be going closer to family. That might be the next personal big move. But of course, wherever I am, I'll have access to Zoom. I'll be in touch.
Oh, well, listen, they need it too. I have a number of people in my Instagram DMs from that part of the world, and they're struggling pretty mightily to understand their diabetes as well.
Right.
So your help will definitely be valuable anywhere you go.
Well, thank you so much. I appreciate it. And that's really, again, and this is what makes being a doctor really fulfilling. You know, it's like if you're able to impact lives and try to help improve people's lives. And
I hope other doctors heard you and I hope they try to match your enthusiasm. I guess that's what I hope. That's really fantastic. Thank you so much.
Thank you so much. Thank you. Thank you.
If you're a physician and you'd like to be on the Grand Round series, please send me an email through juiceboxpodcast.com. I want to thank the Eversense CGM for sponsoring this episode of the Juicebox Podcast. Learn more about its implantable sensor, smart transmitter, and terrific mobile application at eversensecgm.com/juicebox. Get the only implantable sensor for long-term wear. Get Eversense. Having an easy-to-use and accurate blood glucose meter is just one click away. contournext.com/juicebox. That's right. Today's episode is sponsored by the Contour NextGen blood glucose meter. A huge thank you to one of today's sponsors, Gvoke Glucagon. Find out more about Gvoke HypoPen at gvokeglucagon.com/juicebox. You spell that GVOKEGLUCAGON.com/juicebox. The Juicebox Podcast is full of so many series that you want and need. After Dark, Ask Scott and Jenny, Algorithm Pumping, Bold Beginnings, Defining Diabetes, Defining Thyroid, the Diabetes Pro Tip series for Type 1, the Diabetes Variable series, Mental Wellness, Type 2 Diabetes Pro Tip, How We Eat. Oh my goodness, there's so much at juiceboxpodcast.com. Head up into that menu and pick around. And if you're in the private Facebook group, just go to the feature tab for lists upon lists of all of the series. Always free, always helpful. If you're not already subscribed or following in your favorite audio app, please take the time now to do that. It really helps the show. And get those automatic downloads set up so you never miss an episode. Thank you so much for listening. I'll be back very soon with another episode of the Juicebox Podcast. The episode you just heard was professionally edited by Wrong Way Recording. WrongWayRecording.com.